I invite the next speaker, Dr. Dipankar Das. He's a senior consultant at Shankardev Netralay. He'll be speaking on Masquerades, the good, bad, and ugly.
Good morning, respected chairpersons and ladies and gentlemen. Well, I do not have any financial interest in this presentation. This is purely an academic one. Well, Masquerades, when Dr. Somashila gave me a topic, good, bad, and ugly, I was a bit confused. Now you see, there is a common masquerades are non-malignant masquerades, which can be good or bad, sometimes worse also, and which include retinitis pigmentosa, then juvenile xanthogranuloma, pseudoexfoliation syndrome, intraocular foreign body, either a iron foreign body or copper, retinal detachment, which includes a exudative and rhegmatogenous retinal detachment, and ocular ischemic syndrome. Now you see, for retinitis pigmentosa to present as a vitreous cells, these are very fine vitreous cells, and you have a classical triad of retinitis pigmentosa where there is a perivenular pigmentation, then arterial attenuation and optic disc pallor. Patient usually present with night blindness, and you have symptoms as well as signs for it. For juvenile xanthogranuloma, this iris can be involved with a granuloma. There may be a hyphema, recurrent hyphema, which is very, very important. And for systemic juvenile xanthogranuloma, you always look for the xanthoma elsewhere. For example, back of the patient, there may be reddish color xanthoma, which give a clue to you. Now, pseudoexfoliation syndrome, again, this is a where symptoms and signs are very, very important. But in signs, you get a Krukenberg spindles.
Are your slides moving?
Not moving? No, not moving. I'm just pseudoexfoliation. If you see Krukenberg spindle, but Krukenberg spindle in basically in pseudoexfoliation have a diffuse pigmentation, unlike other, and intraocular foreign bodies basically has copper and iron deposition. And retinal detachment sometimes has a pigmentation and can confuse it uveitis, which is called a Schaeffer sign. And in ocular ischemic syndrome, again, this is very, very important because these are very, sometimes can be fatal because of the ischemic syndrome. Now, the ugly part, which I am focusing much more, can be in children, retinoblastoma, metastatic carcinoma in the adult as well as in children, vitreoretinal lymphoma, carcinoma-associated retinopathy, and melanoma-associated retinopathy. Most important thing is the history, very, very important, methodical clinical examination, ancillary investigation, and cross-consultation from the other specialists. Now you see, I'm showing you 6 pictures of all tumor masquerades, okay? And this patient presented with, and I found with investigation, all of them have a cancer sitting underlying. So in vitreoretinal lymphoma, basically an older patient are present with this, male mostly more than female. You can see in immunocompromised as well as immunocomponent. Most important coexisting that they exist with CNS lymphoma, and bilateral is around 80%. Patient present with blurry vision or floater. In slit lamp examination, the cells are a bit larger vitreous cells. They can be in sheets or haze may be there. Fundus, there is a multifocal cream-colored subretinal infiltrate. This is a photo shared by Professor Manfred in 2007 to me and showed a multifocal involvement, and this usually lacks cystoid macular edema. Now, fluorescent angiography and ICG can give some clue, but most important is that in OCT you get nodular hyperrefractive lesion in the RP, and for the tissue diagnosis and the fluid diagnosis, you can do a vitreous step for cytology for atypical large cell lymphoma cell, flow cytometry for CD3, CD20 and other, and PCR for D88. This is basically a genetic location and alteration of IL-6 and IL-10. Brain and spine and MRI is very, very important, because if you get a poll, I remember Professor Manfred once asked in IOG conference, please raise your hand, how many people will do MRI scan in a lymphoma case. Everyone raised in the hall. That's so important because they coexist with the CNS lymphoma. Current treatment not curative, systemic and chemotherapy treatment is advocated. Local therapy include intravitreal methotrexate, and this is repeated injection are given and rituximab. Prognosis is very, very poor. Second masquerade, I'm showing me a 6-year-old child sent from a remote place from our area, and with a diagnosis of intermediate uveitis. In the arrowhead, you see there is a infiltrate. These are the infiltrate in the acid here, and see the pupil is constricted. Immediately I dilated the pupil, and immediately there is an endophytic retinoblastoma in this case. Other is normal. There's a mild dyshyperemia in the right eye. So this patient had a small seeding as well as infiltrate in the antechamber. UVN was given, and MRI showed the involvement of the retinoblastoma. So iris neovascularization can be seen in 50% of the cases in a diffuse retinoblastoma. Pseudohypopian, which is around 32%. There RB seeding can be seen, or iris nodule in 18%. Hyphema can be presenting features. So if you get a hyphema in a child, there may be retinoblastoma seeding. So if ideally you should not take a acetate for draining. But if you drain it, you send for the cytology, you can get harbor a retinoblastoma cell. B-scan ultrasound, MRI, and acetate sometimes is done. This is again a case of 87-year-old lady with post-cancer breast, diagnosed 3 years back, and post-chemotherapy she was receiving, and there was a post-pleural effusion. There's an iris growth which can be seen here. The patient was insisting because she was told by the radiation expert that we need to have a metastatic evidence. So I immediately done an MRI scan which showed involvement, even the ciliary body, and the acetate showed the hyperchromatic nuclei with scanty cytoplasm consistent with adenocarcinoma of the breast, and this was later on the patient was given radiation and extended chemotherapy. See, this is the atypical hypopia. Such superiorly everywhere, and there was a adenocarcinoma from GIT was in this patient. So in MAT carcinoma, occasionally masquerade as uveitis. Most common intraocular malignancy is the secondaries. Lung from male, breast carcinoma can metastasize in the eye. There may be variation of other tumor also. Uveal tract is the most common site, and remember this thing, 25% of the patient presenting with choroidal metastasis to ophthalmology may not have history of cancer. That's very, very important thing. So the take-home message is that pseudohypopian in extreme age is an ominous sign. In pseudohypopian, the dilated fundus examination is very, very important. High index of clinical suspicion and prompt investigation of the masquerades. Thank you for patient hearing.
Thank you, Dr. Dipankar, for that